Thanks for your invitation. I'm Dr. Chalali from France, from southern France, near Cannes. So I will speak about my small learning curve. I began UBE surgery only 6 weeks ago. So my little story. Years ago, I wanted to learn UBE surgery, spine surgery, and I was ready to go to Korea last summer. I already have plane tickets, everything was ready, but COVID came and I can't go to Korea. So at the beginning of the year, I have a complication with infection of dural bridge in the young patients after a discectomy. So I decided to begin UBE without cadaver labs, course or fellowship, nothing. So I decided to try to do UBE only with online formation. I'm a small experience on endoscopic surgery. I did during my fellowship 5 monoportal canal surgery, and maybe 70 monoportal foraminal surgery. So I'm at the online formation, thanks to Dr. Zhang, and began this surgery. So I'm select an easy patient, a 28 years old patient with a huge disc herniation at 5S1, and I decide to do the surgery. If after 1 hour I'm no advance on surgery, I will do open surgery. So when you go to operating room to do a surgery which you never seen, which you don't do any training on lab, and you never see a guy do a surgery, you think that you are doing Christophe Columbus surgery. That means you try to do an operation and usually it's not working. But this is my first surgery. This is these patients, and at the end, the most important question for me is it possible to perform this kind of surgery with a small formation of 2-3 hours? In fact, you see the first surprise when you do this kind of surgery, that you have a very nice view of the space. It's like open surgery. So it's my first patients. I did a very, very nice working space to do the surgery. And after this thing, I will show you a small video of the first surgery in my career. Today it was very interesting to see a lot of experts, so I'm use a drill. This is my surgery 5 weeks ago, and I can remove a piece of bone with a drill. And the most important fact that it's very, very similar to open surgery. This is the S1 nerve root, and you have some epidural fat. There is some yellow ligament, and you see the huge disc herniation of S1 here. So I did this first surgery on less than 1 hour. So it's how I remove this disc herniation. And I not have experience like almost the speakers today. The only question for me is if it's possible to do this kind of surgery. It's difficult. In France, almost of companies say that UBE is very difficult, and you must begin endoscopic surgery with monoportal surgery, because biportal is very difficult. In fact, it's the same view than open surgery. So I remove this big disc herniation. So in France, they say that you must, a lot of guys, they operate 6 months with the monoportal surgery, and they can't remove this kind of disc herniation. So after the surgery, I was very enthusiastic with UBE surgery, and I decided to operate all my patients with UBE endoscopic surgery. So this patient have a good result, no pain. We think it's very interesting. So after this first surgery, before surgery, I have some question for beginners question. Is it easy to do a good working space? Because it's most important question when you do a usual arthroscopic orthopedic surgery. When you do extra-articular arthroscopies, the most difficult thing is to have a good, correct working space. In ISUBE surgery, I see it's very easy to have a great visibility. The water make a space, and with a good radio frequency, you can have a very, very easy surgery. The second thing is it absolutely necessary to use arthropump? In this, with a hydrostatic thing, it was very easy, no problem at all. So, at the end, do you feel in difficulty with this kind of surgery? It's really the same that open surgery. They can't say that you can look more the operating field that with standard surgery. So it's the first surgery was very, very enthusiastic. I've never seen this kind of surgery in real before I did it. It was the difficulty of a situation. So my conclusion after the first surgery, it's why I did not did before this surgery. And I decided to do all my surgery with UBE. It was 1 month ago. So I'm did a lot of, not a lot, but I did some shoulder arthroscopy, and it's almost the same. And when you think about when you're orthopedic surgeon, you know that no surgeon do uniportal knee or shoulder arthroscopy. It's only biportal surgery. So today is 6 weeks of experience. I did 15 surgery. I have a conversion of right side because I'm a problem with hands. I can't operate with left hand, but yesterday I did the right side. And I did disc herniation, I did stenosis, and I tried to have good instrument, to have better instrument. And thanks to this nice meeting, I have a lot of answer to my problems. And almost all patients have a good result. I don't have any complication, any durability, any problem. So already some patients are coming to my consultation for UBE, because in France, we have not a lot of guys which do endoscopic surgery, because France is a developed country, but instruments are very expensive. And we have a few centers use a monoportal surgery, maybe 5, 6. So I'm surprised because this week some patients are coming for UBE. So a few weeks ago, I'm trying to go more and more in UBE surgery, and I did this facial cyst. Because you see, it's a very, very big facial cyst. And the most important point for me in this kind of thing, it's to know what's the best drill, because I did my fellowship in Professor Luac in Bordeaux, and they work on drill, and for me it's very important to have the best drill to do this kind of surgery. So I'm trying some drills, and I don't know what's the best. So the first thing, I'm trying drill 3.5 millimeters from one company, and you see it's cutting nothing. You're beginning with this, and you feel a little bit disappointed to do this facial cyst, because if you use this drill, you can operate 5-6 hours. So I'm changed, and you will see what I did. I decided to use open instrument, open drill, high-speed burr, which is useful for open surgery. And with this, it's very, very effective, because I can remove a big piece of bone very fast. And what's a key point for me for UBE, that you can use open surgery instruments. So with this, it's very effective, but I think you have not so good control of what's going on when you cut your bone. And with high-speed drill, it's very interesting to be very, very near from lower structures. And with this, you don't have a good control of what you are doing during the surgery. So after this, I'll try something. I think it's the best solution, as you see in your videos. It's a birth 4.5, more aggressive. And with this, you can cut the bone with good efficiency on its side, because you see what you are doing. And what's very nice for me in IBE, that you can see on millimeter what you are doing, and you are very effective in your surgery, and you are very safe when you are doing some decompression or something like it. I'm a beginner, but I begin by myself. It's what's some little bit difficult. So after 1 month of learning curve, what you can do after 1 month of learning curve, and your technique is better and better, and you begin to have your small things to do all kind of surgery more effective. Now I did in France called a recalibrage. It's a small stenosis. I know that everyone can do this surgery in these figures, but after 1 month from myself learning curve, I managed to do this. It's a patient with heights with a huge stenosis, and it's a working space. And when you are beginners, your problem for you it's the working space, but now it's not a problem. And you see the lamina. Now I'm do a partiartrectomy and a part of laminectomy. So the most important thing that is not is, from my point of view, is easier than monoportal surgery. Now I'm remove the yellow ligament. In fact, it's a little white because the patient have a lot of corticoid injection. And I managed to remove this like one piece, and after you go to the canal and you can remove some fat, some epidural fat, and some ligament, some yellow ligaments. So I think the main purpose of my speaking, I'm very beginner for 1 month, and very fast you can do almost of usual spine surgery that I used to do in private practice. So I know for you it's very standard, but for a beginner it's very nice for both of you. So as normal surgeon, my perspective, I want to finish my learning curve. I want to try to do some tele by ISUBE procedure. I want to try in the future, when COVID stops in some countries like Korea, China, or Ukraine, maybe, to improve my skills in ISUBE, or use a specific instrument for ISUBE. We are working with a French company to have all the instruments and try to develop this ISUBE surgery in France. I'm very enthusiastic. And I will see your symposium. I'm a Russian speaker, and I will try to see what you say about this. So thanks for this first surgery in France 1 month ago, with thanks to Bon's team, to Dr. Zhang Wei, which did me a good learning session in internet on François Chi. Thanks a lot for this beginner presentation.
Thank you very much, Dr. Halali. You're always welcome in Ukraine after the COVID pandemic. We will invite you if you want to, and we'll share our experience in this field. We have every week about from 5 to 10 cases, so I think it will be useful for you. So thank you very much for your presentation. And next is Dr. Zhang Wei from China. He will share his experience. Dr. Wei, please.
Can you see the screen?
Yeah, yes.
Okay. I'm very sorry. In the morning, I do the ULIF case in the North City in China. But now I stay in the train station in the southwest city in China. I'm sorry for the delayed flight. Today I will share my experience in the UBE clinic application in the cervical case. I'm Dr. Zhang Wei from China. The presentation's content include the indication, basic anatomy and tools, and anesthesia position, location of portals, and surgical steps. Indication include the keyhole for the discectomy and the decompression of cervical nerve canal, and the URBD in the cervical case. The basic anatomy, it is similar to the multi-feeder triangle area in the lumbar case. We will work in the space surrounded by the rotator's longus and the rotator's previous. You can see the laminar and the lateral side is rotator's muscle. UBE cervical case equipment is very simple and relatively small number of devices required. It includes the endoscopy, radio frequency, special tools, and a small size currency punch, and a high-speed drill. Endoscopy, I like the 0 degree. I think is the first choice because it's similar to the open procedure. And how about 30 degree? We should rotate the endoscopy to see the interesting area. And the distance between the view portal and work portal is 2 centimeters. So at such short distance, if we use the 30 degree endoscopy, the tools are prone to conflict. But maybe the ventral structure of the spinal cord is easy to see, especially the disc herniation is located in the midline. Radio frequency, this is a small one. We name it as a nerve friend. It is covered radio frequency. It's very small. I often use this radio frequency in the cervical and thoracic case. It is produced by the Bounce company. It's very useful, I think, especially used for the bleeding control on the surface of the dural spinal cord and nerve root. This is a small dissector. It's also produced by the Bounce company. And this is a half tuber and the UBE retractor. They are used for keeping the outflow fluently. And this is another tuber retractor. We can insert the drill along this tuber to remove the osteophyte near the nerve root. Now I will show the video. First, we use the retractor to protect the nerve root. Then we insert the drill along the tuber. So it's very safe to do the bone work around the nerve root. Currency punch, I often choose 1 millimeter and 2 millimeter and 110 and 130 degree. I prefer the 2 millimeter, the curved punch to deal with the contralateral decompression. We must pay attention to the principle, the dural no touch technique. This is the high-speed drill produced by a China company. It is a special designed for the UBE procedure. You can see the nearly no exposed drill root and a short handle, so it is stable if you use the one hand to hold the drill. And in the cervical procedure, I prefer to the 2 millimeter and 3 millimeter diamond bore. Anesthesia and position is very important. In the majority of the case, I choose the general anesthesia and control the low blood pressure and relax the muscle, and the deep anesthesia and jet plane position. Location of the two portal, my opinion is located in the disc level and the midline of the lateral mass. Then the work portal and the wheel portal, the distance between the two portal is about 2 centimeter. We pay attention to the two pedicle, the circle, the red circle. The lateral X-ray should confirm the position of the two portals. The distance is 2 centimeter. For example, the C6 or C7, we use the first root to locate it in the on the laminar. Is very safe. Then we build the portal of the cervical 7. Is also located in the laminar of cervical 7 or cervical 6. At last, the endoscopy and the radio frequency meet with each other on the laminar. The waypoint is very important. Waypoint is similar to the uniportal. We do the bone work from the waypoint. I like using the diamond drill to measure the decompression area. This is a lateral mesh joint. You can see the facet joint. The start point is located in the waypoint. Sorry. The dividing line of the flav ligament is very clear. We often find that this membrane is not dural. It often appears on the surface of the nerve root. This is a decompression area. How to make sure the decompression area? We must use the radio frequency to touch the lateral wall of the pedicle and the medial wall of the pedicle. The lateral wall of the pedicle is we can do the decompression to the lateral wall of the pedicle. We also use the size of the diamond bore to measure the decompression. After finishing the keyhole decompression, we often do the further decompression of the spinal canal. At last, we see the medial wall of the two pedicle. And then we finish the decompression of the keyhole procedure. You can see the medial wall of the two pedicle. Case one is a giant osteophyte. It's very big. I choose the contralateral approach. Left side is caudal, right side is cranial. This is the upper margin of the C4. C4, C5. The inferior margin of the osteophyte. The upper margin of the osteophyte. Osteophyte under the free bone fragment. I remove the free bone fragment. Then separate the free bone from the spinal cord. So we can see the contralateral nerve root and the contralateral facet joint, finishing the decompression. This is the result. Case 2 is the traditional technique, the cervical URBD. The left side is the cranial, the right side is the caudal side. You can see the inner plate of the laminar. After removing the laminar, we can see the flav ligament. Then I use the same method to remove the cervical 5 laminar. I finish the decompression. For contralateral decompression, I think the midline is very important, especially the structure between the spinal process. I use the big radio frequency to open the ligament between the spinal process. And then we can go to the contralateral side. So I use the kerosene punch, the curved kerosene punch to do the contralateral decompression. The midline is very important. It is the door for us to go to the contralateral side. It's different from the lumbar URBD. Take home message. The anatomy is very important. The workspace and the start point, the right tools and the right operation indication is also very important. Cervical UB anesthesia, the low blood pressure and the jet position and precise location of the work portal and view portal. Identification of the waypoint, it is the start point. How to make sure the decompression area can make sure you will not make a mistake to cause the unstable. Thank you, everyone.
Thank you very much for a wonderful presentation. I just have my only one case of the cervical UBE, but I think I will improve my skills in this field. Thank you for a great presentation. So the next lecture will be from Ukraine. Taras Voloshin will tell us about the basical principles of full endoscopic spine surgery. Dr. Voloshin, please.
Thank you so much for inviting Dr. Jakub Fishenko. It's a big honor to be sharing my experience. So I would like to talk a little bit about basic principles and basic stuff and share a couple of cases. So I will talk a little bit about the indication for endoscopic discectomy, why preoperative planning is crucial, and which kind of discerniation is possible for endoscopic discectomy, and what is the advantages of endoscopic discectomy. This slide is showing us the main benefits of endoscopic surgery. It is small incision and it is less invasive. And here is a little history how the invasive and incision was getting less and less. And finally, this is the map of the this herniation. It is reachable for endoscopic surgery. Basically, all kind of disc herniation in lumbar spine, all localization is reachable for endoscopic technique. Transforaminal approach is my favorite one. And it is possible because of safe zone called Cambium triangle, and we can see here, thanks to special manual drills, we can even widen the foramen also. This is a special instrument with manual bores, which can provide such a approach. It is pretty straightforward technique, and first step is to reach tip of SAP and provide anesthesia, and then with special Tomshidi needle enter the disc herniation, and independent where is our disc herniation, we should reach with our tip of Tomshidi where is our herniation, and then widening foramen with hand reamers. And if preoperative planning and approaching with Tomshidi needle was right, the only thing we will see on endoscope will be disc herniation, disc fragments. And after removing, we can see the compressed nerve root. But I would like to share a couple of my cases and show why preoperative planning is crucial. So here is young male with huge L4, L5 disc herniation, and every time before doing surgery, I do preoperative planning on MRI, because we have different disc location, we have different joints, facet joints. So I would always do desirable trajectory. and then I would measure the entry point based on MRI. So I'm not using any standard numbers. I always measure individually. So here would be around 15 centimeters for skinny patient. So it is pretty lateral approach. So here we can see deleted fragments, and next day MRI. Here is interesting case. It's a young patient, nurse. She had pretty severe pain, about 9 or 10, and pretty interesting disc herniation. It is pretty small, but pretty dislocated caudally. So the planning was, entry point was quite high to reach the mid of this herniation. And here we can see our needle and local anesthesia. Then we can see the Tomshidi needle, then advancement of Tomshidi needle to the base of this fragment, then reamering. And then working sleeve. And here we can see our endoscopic feature. So we landed pretty much in the center of this herniation. So this is cranial part. And here we can see on the 9 is a caudal. And here we can see decompressed traversing nerve root. Next day MRI, and no pain. L5S1 is also accessible for transforaminal approach because of manual reamers. And here we can see the approach with hand reamers, and here we can see our forceps. And we can see decompressed nerve root, which is pulsing. And deleted fragments. Here is also pretty big disc herniation. A young patient, firefighter, with Taizhou syndrome. And pretty much standard approach. It's like fishing. Huge fragment. And this is what we got. Also, next day MRI, and you can see dual sac at that level. No neurological deficit. Patient went home next day. Here is an interesting case. It is reherniation 3 years after microdiscectomy. And we were expecting a lot of scar tissue posteriorly, so we went lateral, the extreme lateral approach. And this is the pregnancy we got, and patient went home next day. Limitation for transforaminal access is high iliac crest for L5S1 and severe cranial migration of the cluster. And the next approach, which is helping us in such a case, is interlaminar approach. It is also pretty straightforward procedure. The first step is to define entry point on skin. It will be right on the middle of interlaminar window. And then advance to the facet joint, then shifting a little bit medial, open ligamentum flavum, and find lateral border of neural structures. And clinical case, quite big disc herniation on L5S1 on the right side. Whole herniation was in one fragment. Even though endoscopic disc surgery, I like this slide so much because it's showing that the most complex the surgery, the biggest is benefit. Discectomy is relatively easy procedure, but even for discectomy, endoscopic technique is giving benefit. So endoscopic spine surgery is self-sufficient in terms of solving lumbar disc herniation. Also, it is minimizing invasiveness of traditional spine surgery. And also, it is a good option in solving reherniation after standard and microdiscectomy. Thank you so much.
Thank you very much. Thank you very much, Dr. Voloshin. Thank you very much. And next presentation will be from Kyiv, Ukraine, Alexander Kovalenko.
Hello, everyone. Dear colleagues, I would like to show you my presentation on the topic physical rehabilitation after surgical treatment of patients with lumbar spinal stenosis. 84 to 90% of the population have had lumbago through their lives. Due to the aging of the population, the frequency of low back pain is increasing. 10 to 90% of patients aged to 50 to 17 suffer from symptomatic lumbar spinal stenosis. LSS is the most common cause of spinal surgery in patients over 75 years old. According to the results of the meta-analysis, it was revealed that the clinical symptoms of LSS are most pronounced in patients aged 60 to 75 years. While it's important to know that this is age group, CT and MRI image of 60% of patients confirms the diagnosis of lumbar spinal stenosis. Also, as you saw on the last slide, it is symptomatic only in 40%, therefore, along with objective studies such as functional radiography, CT, and MRI, we always take into account the symptoms and results of a physical examination. In this context, mention should also be made of the differential diagnosis of stenosis and to some extent the similarity of symptoms of central stenosis of the spinal canal and vascular pathology, such as obliterating endothelitis or atherosclerosis of the lower extremities vessels, which will also cause neurogenic intermediate claudication syndrome. That is why it's so important to always compare the symptoms and the X-ray pictures. Since 2018, the Institute of Traumatology and Orthopedics has performed 246 endoscopic surgeries during biportal method to herniated disc, as well as 211 operations for a patient with spinal stenosis in the lumbar spine. While in Ukraine, a total of 136 operations were performed using biportal endoscopy. We monitor all patients to this day and help maintain the good results of surgical treatment. For your attention, a clinical example, it's interesting because he once showed all the stage of conservative treatment, namely in 230, he underwent the procedure of epidural adhesiolysis in Ukrainian clinic, after which there was an improvement every half a year. The symptoms worsened, but the course of the conservative treatment, like non-steroidal drugs, was enough to stop it. Approximately 1 time per year, a caudal epidural injection was performed and had a temporary effect. A month before operation, another exacerbation occurred that could not be stopped by non-steroidal or epidural injection. After that, he was admitted to the hospital of the spine surgery clinic. We had underwent surgery by the method of biportal endoscopy. After the operation, the pain syndrome on the WASH scale decreased from 8 to 3, and immediately we proceeded to rehabilitation in our department. The patient underwent a full course of rehabilitation for 40 days, after which he was observed on an outpatient basis and underwent outpatient treatment according to an individual program. During the whole time, this is a positive trend. As we know, the condition of the paraspinal muscle allows us to control back pain. Also, the prognosis for the next 3 years depends on the state of the paravertebral muscles. What do we, as orthopedics in rehabilitation, attention to? First, as you see, is the diameter of the disc and the diameter of the musculus psoas major at this level, like this example L4. It's considered normal if at the level of fourth lumbar vertebra, the diameter are equal. Next, fatty degeneration of the paravertebral muscles, like in multifidus and the extensor of the back. Like this patient. By the way, in almost all patients in this age, we observe fatty degeneration to 1 degree or another. The condition of thoracolumbar fascia, which should be convex and not have a white fat layer. In this case, we see a good fascia, but already formed fat layer. It tells us that the patient was once engaged in physical activity and his the physical activity and his muscle were in good condition. And we know that the patient has been working as a driver for the last 10 years. And the last one is the muscle symmetry. There are no confirmed scientific studies yet, but from our experience, I can say that the symmetry of the muscle is of a great importance, because from the MRI, you can even see how on one head the muscle is a normal tone and the other is atrophied. And it will also affect the characteristic of rehabilitation. Rebuild function, not anatomy. This is especially true when it comes to your core and lower back. The spine is unique multisegmental joint that requires mobility and stability in different areas to operate at full capacity. The joint areas of the body alternating purpose between mobility and stability, as you see on this picture. For the joint-by-joint approach, the lumbar spine is meant for stability. Below it we find the hip joints, and above it we find the thoracic spine. In both of these areas, we are looking for the opposite of stability and mobility. Having adequate mobility in the hip joints and thoracic spine enhances our ability to create a stability in the lumbar spine. With this concept, we can begin to understand that the lumbar spine was designed to provide stability, and this is the most important aspect for the development of the cortex. So our specific features of rehabilitation include, first, of course, its individual approach, beginning of rehabilitation at 1 day after surgery, neuromobilization from the first day, using flexion exercise in the lumbar region, walking on the treadmill in a flexed position, exercise to strengthen the core muscle, and isometric lower back exercise and stretching exercise. There are also rules of conduct that we inform patient about, namely avoid bending forward for the first 40 days after surgery, avoid lifting heavy objects for minimum 1 month after surgery, eliminate side tilting and rotation. We always, to patients after surgery, recommended to wear a lumbar corset. This provides not only unloading of lumbar spine, but also a disciplining function. It's allowed to sit for no more than 20 to 30 minutes while maintaining an even back position. The features of rehabilitation period, early and late. Early postoperative period lasts the first 4 days after surgery, and as you see, the late period consists of 2 stages, 5 to 21st days and after 3 weeks. We begin to verticalize patient, as you see on this picture, at first day after 2 or 3 hours after the operation. We begin neuromobilization exercise to the same day, with the help of rehabilitation therapists and in a painless range. Also, as you see, the patient together with the rehabilitation therapist begin to perform isometric low exercise in low amplitude, pulling the knee joints. From day 5, we connected exercise with flexion in the lumbar spine. We begin to strengthen the muscle of the core, namely all the muscles that are attached to the hips, pelvis, and lower back. We always strengthen quadriceps, gluteus medius, gluteus maximus, and lats. Isometric lumbar and stretching exercise, it's also imperative to strengthen the muscle of the lower extremities and buttocks, because this structure is one of the main stabilization structure of the entire spinal column, which are compared to the masts of a ship. From first week after surgery, we recommended the patient start walking on the treadmill in a flexing position, and like in these pictures, balance exercises for the lower limbs, exercises on the balls that allow you to exclude hyperextension and overload of the lumbar spine, while including the thoracolumbar fascia and paravertebral muscles in the work. And as you see on the down pictures, we also connect in a late postoperative period portative myostimulation apparatus, and this is very effective to start working paravertebral muscles. And I also like to note that, taking into account that the average age of the patients and the quality of the paravertebral muscles in rehabilitation, individual approach is required. The condition of our clinic allow for outpatient observation and participation of rehabilitation to patients for a long period, as well as in connection with the change introduced by the coronavirus. We are actively introducing online training even with older patients. We are not tasked with building muscle. The main task of rehabilitation is to increase the endurance and functionality of the muscle by training them in a stable and atraumatic mode. Minimize the number of the areas of fatty degeneration. We increase the number of mitochondria and energy substrate. These features of treatment and rehabilitation allowed us to achieve a lasting improvement in the quality of life of patients, namely decrease, as you see, in VAS scores from 8 before operation to 1 to 2 after 6 months, improvement in the quality of life, which is indicated by OSWES-3 index from 74 before operation to 20 after 6 months. And finally, I would like to say function affects structure as well as structure and function. Thanks for your attention. Have a great day. Goodbye.
Thank you, Dr. Kovalenko. So now we will have the last hour presentation, and I want to introduce you Dr. Malcolm Pestonji from India. Please, doctor.
Good evening and welcome to our talk today on contralateral sublaminar extrafleval approach for foraminal stenosis using the technique of unilateral biportal endoscopic decompression. Basically, what is foraminal stenosis? It is the narrowing of the bony exit by which the nerve leaves dural canal, and it is caused by a decrease in the height of the disc, by a craniocaudal subluxation of the upper ending of the superior articular process, and by buckling of the ligamentum flavum and bulging of the disc. So basically, these are the contributing factors which cause foraminal stenosis. Why UB? UB is basically surgery done with two very, very small portals, 3 millimeter cuts. One is a working portal, one is a scopic portal. The medium of fluid is normal saline. It helps in tissue dissection and absolute clear vision. It is truly a minimalistic approach. It passes through some fibers of the multifidus, and usually in the fat space between the multifidus and the lamina is where we create our reservoir. There is only dilatation, there is no cutting, there is a 4 millimeter scope and routine instrumentation. The advantage of a 4 millimeter scope is you can, it's like chopsticks, you can work on very nice. You can reach all possible corners. An advantage of a 30-degree scope is allows you proper visualization of foramen. You can see right deep foramen and beyond. So, how do we start? We start with cutting out the base of the spinous process, decompressing that thing, and then starting with the sublaminar decompression on the opposite side. This is to allow us to come to the opposite foramen. As you can see here, I'm using an oval burr and I'm cutting through the base of the spinous process so that I can push my instruments more horizontally and perfectly onto the opposite side lamina. Cut away the inferior edge of the superior lamina on the opposite side until I get a separation of the flavum auto-separating itself from the base of the lamina, cranial lamina. So you can see over here, we are burring away onto the opposite side now. And you can see slowly how the flavum is detaching itself. So we know okay, we are reaching the isthmic junction and we need to expand that junction further, go more laterally, and then go on to the facets. So that's the way the whole sweep or the whole arc of the movement is. In the next slide, you can see that There's an image on the left, there's an image on the right. The image on the left is an L3-4. But here you can see that I have taken two core sectors, ipsilateral and contralateral. Sublaminar decompression has been done on the contralateral side. I've thinned out the lamina, cut away the excess bone, opened up the lateral canal adequately, and I've done a similar job on the ipsilateral side. Now on the L4-5 image, if you see, you will realize that I've done everything only on the contralateral side. My pathology was contralateral, my foramen was only one block. Why do I need to do anything on this side? No need. So I did only a contralateral sublaminar decompression. So that basically is how you plan your sectoral approach in this surgery. Now, when you reach the contralateral lateral inserts, you need to decompress that too. So lateral decompression is that we do, especially I do. I try to do it extra flavouring. I preserve a layer of flavum between me and the facet so that the dura is protected. I'll play this video and you'll be able to appreciate it better. You can see the drill is now taking its position above the flavum, which is in the lateral recess. And yeah, that's the bony edge. And I'm starting to burr away, make it bigger and bigger, bigger and bigger, moving cranially towards the foramen. Undercutting of the SAP is occurring right now. That little bony red margin that you see, that is the IAP-SAP junction. And we are cutting and opening up that whole lateral recess over there. And when I finish this burring, you will see there's a thick layer of flavum that is actually there. That flavum has been what has been protecting me during my burring. So it's not as rash as it seems, but it's quite well controlled. Yeah, you can see the flavum that is down there. Next step would be to identify the deeper part of the SAP, part that swings right below and out into the foramen. So again, we are doing an extra flavor in this section of that. You can see how I'm stripping away the flavum. You can see this whole mass. I will mark out this whole mass over here. This is the SAP. I'm targeting this SAP. The IAP line is here. This is the IAP line, but this here is the SAP. And now I'm putting my chisel over there. It's a hockey stick chisel. It's a J-shaped chisel which comes with the endoscopic UV set. And I am now doing an osteotomy. Carefully, I'm osteotomizing the tip of the SAP. We will be separating it out completely. And we'll be able to see wonderfully the root below, the exiting root below. As you can see, there's a whole flavum over there. Nothing of the dura is exposed as of now. So we're quite safe and we're quite comfortable in what we are doing. I advocate this extra flavor approach, though it takes a little time for some people to understand it. It's far safer than working on the dura itself. And you can see how we are cracking it open. Going deeper, trying to push through the entire foramen. The cannulus bone that you see above is the IAP. Below is the tip of the SAP, which are fractured. Yes, now it is fractured, and as you can see, the whole root lies exposed below, covered with a little bit of foraminal ligament or flavum, whatever you wish to call it. This is the osteotomized surface. And below you can see the beautiful root and the entire exit completely opened up, beautifully opened up. So that is a take home from this, that you can do an SAP contralateral osteotomy. Sometimes it becomes difficult. I won't say impossible, but it becomes difficult to even do an osteotomy. You try to do an osteotomy, but the bone is just too thick. It's just too thick. It's just not possible. I'm now using a curette, using a small curette to clear out as much of the SAP tip as I can and try and create a tunnel over it. A tunnel in which I can then gradually introduce a diamond tip protected, guarded with the root and dura below, so that I can expand the exit part of the foramen. And as you can see now, I've taken position and I'm burning towards the dorsal surface. I'm going cranially and dorsally in both directions. I'm trying to open up the foramen as far as possible, out as much as possible, and as clearly as possible. Yeah, that is the outer edge, and we are going through there. We are opening it up thoroughly. There's a little bit of a dip of the lateral recess and the foramen over there. So we will burr that also. But you will be realizing, and you can see now, how beautifully our instrument is going across the entire facet. So we have comfortably opened it up. This is the image. Post-op CT reconstruction. You can see that the tip of the SAP is gone. Foramen is nice and wide. And here you can see a ball probe tip going through the entire foramen out on the opposite side, ensuring the fact that we have really freed up everything over there. So I thank you very much for giving me this opportunity to address you. I look a little haggard, but I'm not well. Thank you once again.
Thank you very much, Dr. Malcolm. Thanks to all faculties for thank you all the faculties for sharing us the rich and generous lecture today to bring us a full day of knowledge. Thanks for all audience attention and questions. Thank you that you spend us all the day. We will keep in touch with you via email. So thanks to Bonds Company for support for the all-day conference. It's almost 11 p.m. in China, so let's end the conference. Thank you very much. Have a great day, have a great weekend, and hope to see you again with us and with the Bonds Company conferences in later. Thank you. Bye to all.
Thank you, Dr. Fichenko. Thank you. Bye.
Bye-bye.